Hey guys, you're watching the Best Practices Show, where we take a look at the best business practices from the best dental practices anywhere in the country. And if you're striving to be a great restorative dentist, you know how important phasing treatment is. And so today we're going to talk about the 3 big reasons you should phase treatment with my good friend from the Dawson Academy, Drew Cobb. Do not miss this. So do me a favor, grab a pen and hit the share button. We'll see you in a few seconds.
The Best Practices Show with Kirk Barrett is brought to you exclusively by ACT Dental, the ultimate provider of dental practice management solutions for dentists and their teams. ACT Dental is committed to helping you build a better practice and a better life. If you are looking to grow your production, motivate your team, get back on track, and create the practice you've always dreamed about, look no further. Give us a call at 800-851-8186 or visit us at actdental.com.
Hey guys, welcome back to the Best Practice Show. Thank you so much for watching. And again, we're having so much fun doing these. Got quite a bit of activity and a lot of suggestions for great shows, and up over 60,000 followers on iTunes and over 21,000 on Facebook. So keep watching, keep sharing. We really, really appreciate it. And a couple things before we get started with my good friend Drew, which is going to be a great episode, so you don't want to miss this, is we are shooting this particular episode live on Facebook. So do me a favor. If you have a question, add it to the feed, and I'll ask Dr. Cobb himself, and we'll get the answer straight from the master while he's on the show. Or if you have a question later on and you want to ask it, go ahead and continue to add it to the feed, and we'll get back to you with a good answer, because we want you to get the most out of these shows while you're watching them. So Drew, thank you again for being back. I always thank you every single time. You add so much value every time you're on.
It's always great being here with you. It's always a good day when I get to spend some time with you, Kirk.
Oh, buddy, you're so kind. Now, you've been traveling the world. I want you to introduce yourself. If people don't know who Drew Cobb is or the Dawson Academy, share us a couple thoughts. But you just got back from Prague, and then you're going to China. You got a lot of, you're all over the place. Get us caught up on what you've been up to and who you are.
I'm all over the place right now, but it's all good, and it's doing something I love. I love dentistry. I love the Dawson Academy. Was 25 years ago now, I guess, I went through their curriculum, and it changed my life as a dentist. I mean, I love dentistry. I love what we're able to do. But, a number of years ago, I was really kind of burnt out with what I will say is kind of the usual, customary, reasonable dentistry. It was just turned into a grind. I mean, I was overworked. I was overstressed. I couldn't work any harder and produce any more. And I had heard of Pete Dawson. He had kind of lectured at Georgetown when I was at school there. And I wanted to go listen to Pete. Now, this is 25 years ago, and when I listened to him, it's like he was talking just to me. All the struggles I was having as a dentist in my practice are the things he was talking about. And it was really about a different way to practice dentistry, and I think a better way to practice dentistry, and with better long-term success for our patients. So I ate it up. The hard part was the implementation part, how to change your practice. And I get it. Change is hard. You have a way you're practicing, and you can pay your bills and live a life and everything else. And it's hard to change that. But if you do, wow, it's almost exponential, I think, what we can do. So it really changed my life. And I've been fortunate enough to be on their faculty for the last 10 years or so. I'm the director of the core curriculum. And now we have so many places abroad that we're teaching, not just in the U.S., but overseas as well. So I've gotten to meet so many incredible dentists that are really trying to take the time and do things right. And it's a pleasure to work with people like that.
Yeah, and I'll back you up on that, because it really is a lot of fun. I'll be with you guys at Seminar 1 in a couple of weeks. So if you haven't been, got to go. So good stuff. Now, today we're going to be talking about sequencing treatment. And, Drew, you've been on so many times and talk about the new patient process and all. Let's just back up and give this the big picture first. Sequencing treatment in great restorative dentistry is important, and you've learned a lot in your journey here.
Yeah. So, early on, you learn to do the examination, you learn to get the records, you learn to do the treatment plan. And for people with some complex needs, you can design what I'm going to say is really incredible treatment plans that are going to solve their problems. The frustrating part, and it has happened to everybody, and happened to me, I tell people, listen, I've made every mistake in the book doing this kind of dentistry. So learn from our mistakes. If we can make it easier for you, that's what it's all about. But when you get that treatment plan and you're committed to it and you know it's the right thing, you have the conversation with the patient and you just think that they're going to say yes, And then you move on and you do the dentistry. That's the fun part. But some of this dentistry, complex dentistry, it can be expensive. I mean, we're talking tens of thousands of dollars. And if you think that at the treatment planning appointment, you're just going to drop an expensive treatment plan on a patient and expect them to say yes, you're going to be in for a surprise. I mean, I've done it, and there's nothing worse than presenting a expensive treatment plan to somebody that was not expecting it. And so that's kind of what we've learned through the years. You talked about going back to the basics, and it's actually a great point, because treatment planning starts actually at the examination, not at treatment planning. Like if by the time we present a case now, you should have had conversations with a patient and getting some kind of budgetary idea for them. So now you're just trying to figure out how they can get the care within their budgetary restraints. It's a much better way of doing it. And it kind of goes back to one of those things Pete has always said, Kirk, that, we're the advocate for patients' health. And if you have a treatment, I call it a treatment option review, where we're just having a conversation. And here were your problems. Here are the things that we said we could maybe do. This is what you wanted me to proceed with. Here's the plan within budgets, that you're going to come up with. And now it's just talking about how you go and get the care. But it starts at the beginning, so that first slide, I mean, we start talking about the process, those 4 prongs to the examination. This really is the outline of complete dentistry. And I think this way every day, every patient. I get into trouble when I don't, when I start skipping steps. But honestly, the foundation of the pyramid would be the exam and records. The exam is honestly, you're just trying to find out if the patient has problems, whether they're bacteriological problems, functional issue, aesthetic issues, or, now those airway issues we talk about. And as you do the examination, your patient's part of it, you're describing the issue, and we talk about signs and implications. Here's something that we see. Your teeth are wearing down. This tooth is fractured. That's the tooth you're hitting on and you're grinding on. There's a reason this is happening. The muscles on that side are sore. You start to tie things together rather than just telling somebody they need X, Y, and Z. And that really is the key to the whole process. By the end of a good, complete examination, the patient is going to do 2 things I found normally over the years. One is they're going to thank you, because no one has ever spent the time with them to do this. They're used to somebody going around with a chart like we learned in dental school. Not that there's anything wrong with that, because you got to start somewhere. But you go around with a tooth chart and this tooth is okay, this one needs a crown, this one needs a filling replaced, and that's it. It is tooth by tooth dentistry, and you're not looking at everything. The patients get it when you slow down and you take the time to look at everything. This isn't rocket science. There's nothing hard here. There's nothing that every dentist out there can't do if they want to do it. But that's the process that happens. So they'll thank you. The second thing they'll say is, how do I fix it? How do I get healthy for the long term? Now we're doing this together.
Right.
There's nothing worse than having a patient come in and they think you're trying to sell them something. That is not what this is about. Those appointments never go well with patients that have that. I'm here to help you. You want me to help you, and I'm all in. I'm going to do everything within my power to give you the best result that I can possibly do. This is what makes dentistry fun. Yeah. But it's that examination, Kirk, that starts the whole thing, especially treatment planning.
Yeah, can I ask you a question about this?
Sure,
because
sure.
Now I do get this question. If you're listening to this and you're a young dentist, the exam is something you've really worked on for years, and it's not 15 minutes with a patient. Correct. So there's 2 pieces I'd love to know. How long is your exam? And then the second thing is, you guys taught me so well, it's about connection. It's not about data. Yeah. So can you speak to that?
Yeah, 2 huge points, very important. One is this is not a 15-minute exam, but it's not a 3-hour exam either. I mean, generally, I'm going to say I take about an hour for an exam. And as long as you have processes, meaning laid out, like you have your exam, you do step 1, step 2, step 3, and we have everything laid out in the Dawson Diagnostic Wizard to streamline everything and make sure we don't miss anything. But going through the data part of it, it's an hour. But as you go through each one, what it gives you is I tell the patient what we're doing and why, and they're part of it. And then they can ask questions, and then we can ask questions of them. back at the exam too, early on, this is where we're first meeting a patient. They don't know you. I think trust is a huge thing in treatment planning for patients. I mean, just think about what we're asking patients sometimes after maybe 2 appointments. We think they're going to trust us to do expensive dentistry and start doing what we do to their teeth. I think that is a huge trust issue. But it starts early on. It starts in the examination, I think. So it's taking the time to go through that. And you can't do it, Kirk, when you're doing triple hygiene and every 5 minutes you're up to check a hygiene patient. So somewhere in your schedule, you got to take the time to do it. You're dedicated to that patient for that hour and a half if you want to. When you start, it's up to you. You're the doctor. But you got to have dedicated time where you're committed to that patient for that time frame.
Absolutely. Now, before we went on, you used the word puzzle. I want you to talk about that.
Yeah.
And then also, too, when we talk about these 3 options, you're putting all the before we get to the treatment option review. So just talk about your philosophy behind the puzzle.
So if you throw up the next slide, that'll help with that question, too. And this is, again, part of our process, that 3D. We go through a 2D and a 3D treatment planning process. So you get the examination first. If it's a patient that needs this kind of dentistry, and you got to remember, not every patient does, and the only way you're going to be able to decide if the patient does or does not need this kind of dentistry is to do an exam. So, if you do an exam and everything comes out and everything's fine, you know what? We don't take that patient through these processes. You can treat them like you're doing most of what I will say, your general patients. It's when you go through the exam that they have more extensive needs that we need a better pathway for those patients. And then that's going to be getting the records, the photos, mounting the case and everything else, and then going through our treatment planning processes that we refer to as the 2D and the 3D. That's the puzzle. And to me, that's a lot of fun. So you've done the examination, the patient wants you to solve their problems, you've acquired the data that you need, and now you sit down again, a quiet time, you don't have patients here, morning, later in the day, whenever you want, the dedicated treatment planning time, and you put the puzzle together. What were the problems? How can we solve them? How can we solve them with the least amount of dentistry to our patients? And then the next part of that puzzle, if you've already had the conversation, is now, because you got to decide on what is the ideal treatment plan. So we're not skimming on that. So if they need a lot of stuff, they need a lot of stuff. Remember, it's not our problems, it's the patient's problems. We're trying to help them. But if they need a lot of dentistry and there's budgetary constraints, now the next part of the puzzle is, how can I break up this treatment, even if it's extensive, within the budgetary restraints of my patient? And again, to me, that's fun. I mean, it's easy to just come out with these elaborate, big, expensive treatment plans. And it's always great when somebody says yes. But that's not everybody. Some patients, they still want it. They want the best care they can get, but they just can't work that out within their restraints. So if we can break things up into small pieces that they can tolerate and work with, now maybe the treatment is not done in a year. Maybe it's done in 2 or 3 years. And you know what? That's fine. Because every time we do something, we're getting better. And that's a lot better than for that patient, this piecemeal dentistry where we do one tooth here and then another one breaks and we do another one here. That's not going to set them up for long-term health. Yeah. So it's that process, but you got to get in space where you think things need to go. So that's the treatment planning protocol. And now you get to figure out how can we sequence it and break it up.
Awesome. So take us through this. When you look at the 3 reasons and how you think as a clinician, take us through them.
So, I mean, the 3 things I'm talking about, budget, time, and success. I mean, listen, we want to be successful. So you want your patient to say yes to your treatment plan. But it's not going to happen unless you work the time and the budget out within the patient's constraints. So the budget, you got to have a conversation somewhere along the line with the budget. And Kirk, you maybe have a lot more info on this because you've been dealing with this for a long time too. But I think that's, especially for younger dentists, for whatever reason, we don't want to have that conversation with a patient. Yeah. We don't want to ask them. We don't want to talk about money. I mean, I remember years ago, Kirk, when I was first doing this, I would hear some consultants say, oh, the doctor never has the money conversation with the patient. You bring in your senior staff member, whoever is going to do that. That really doesn't make sense. I mean, I'm fine having that conversation. But I do remember early on, it is the last thing I wanted to talk about.
Yeah.
So now, and I kind of got this from John Cranham and Pete Dawson a little bit. One about it's okay to just have an open conversation. Again, back to that, I'm their advocate for the health. So at the end of this, you can have a pretty good idea where some of this is going, whether people need a lot of treatment or not. So there's always kind of a simple question I ask. Is there any reason that you could not get the care that you deserve, whether it's time or finances or anything else? Let me know now, because as I try to put this puzzle together, I'll try to put it together in a way that is going to work for you.
Yeah, that's beautiful, because you're asking them to introduce any roadblocks.
That's it.
And you're going to help them through the roadblocks, which is awesome. Now, I want to ask you this, because this question comes up. Where do you ask this question? Is this at the end of the exam, during the exam? And then oftentimes when patients bring up budget, they may not have an answer when you ask it to them the first time, right?
Right. So I definitely want to have the conversation at the end of the exam.
Okay.
At the end of the exam, especially if it's that patient that we've deemed what we'll refer to as a specialty patient, a patient that needs this kind of dentistry. So definitely that. Sometimes those patients come back again for the records process, the photos and everything else. And I'll have a brief conversation again. Same thing again, because now I've got the info that I'm going to put together. Again, tell me so that I can put this together in something that works with you. Because the last thing I want to do is to do that treatment planning and blow the patient up because the fees are just not within what they were thinking.
Right. And the perfect lead-in, you said the two things that patients will say is, how do I fix it? That's the perfect lead-in to maybe introduce some of those things and not know exactly what they are just yet, right?
Absolutely. Absolutely. And I think it's an easy conversation. Listen, this kind of dentistry can be expensive. So, again, just let me know, where we are. And I think for the majority of patients, you'll come out with something that you can work with. And, there's going to be some patients that they just don't have the resources, and they need extensive treatment. And that's always, I think, for me, kind of the gut-wrenching one, especially people that they really need it, but it's hard to achieve. And dental insurance doesn't work for patients with more complicated needs. It's just, $1,500 a year isn't going to do it for some of these patients. But again, Kirk, I think the big thing is that you're on the same page with the patient. You're there to help them. You're not trying to force them or talk them into any treatment.
Right. And the big thing, I totally agree with what you've taught, and I've learned from you guys, is you just want to know oftentimes what the patient's thinking, because if they're thinking $500 and you're thinking $15,000, which I'm sure happens in your office. Yeah. What happens when people say, well, I only have $500 and you're thinking $15,000? Yeah. Give us some insight. What do I do as a young dentist?
Sometimes the budgets have to change.
Right.
I mean, so I'm going to say this works for most people, but there are going to be people, that $500 isn't going to cover full mouth rehabilitation, no matter how I break it up. You know what I mean? So, and then, those patients, maybe that finance talk, you can talk, get them with, some of the dental finance companies out there that you can work with smaller chunks with that. So you can still try to do things. I mean,
but my hope is this: if you're watching this, you get a sense that Drew's an excellent dentist. By the time you've had all these touch points, you've got an excellent exam. You're making good connections with the patient. They're not thinking this is cheap. So if they sit through your exam and they ask about a discount or a Groupon, you're not really doing a great exam.
No, exactly. No, that's not working. Yeah. But the other thing with that patient, Kirk, that you were just referencing is that, remember, at the end of the exam, we're not proceeding with all of the records and everything else unless I get a yes from the patient. Okay. So if that initial conversation, is there anything that would stop you from doing this? And they say, listen, I only got $500 or something else. The backup then is, well, here's what we're going to do. Let's take care of all the bacteriological stuff. Let's try to prevent stuff from getting worse. So now we're back to what dentistry is good at. If there's decay, take care of it. Core buildups with composites, get the perio control, that sort of thing. If there's functional issues and breakdown, I can substitute by using a removable appliance. So I can use some type of orthotic, which is designed based on what the exam told us. We can park the patient in that. I'm still doing the best I can for them, We're going to maintain the bacteriological stuff. Perio is not going to get worse. We'll take care of decay. We'll slow down the functional stuff from happening. And then when they're a better spot, I'm here to help you. And then they come back and you start the records and this process again. And that's actually worked for me a lot, especially when we go back and talk about that trust issue a little bit. Some patients can meet you 2 or 3 times and they're all in. Others, what I found, Kirk, is that, you know what, keeping them in your office for a while, they come in for hygiene, you've done the initial stuff, maybe touched up a few fillings here and there. You don't want to go to definitives. I'm not doing crowns and veneers on that patient. I'm doing good interim restorations that'll take care of the problems. I'm trying to slow down the bad stuff from happening. But you know what? 6 months, a year, 2 years, 3 years later, something will happen, but you still taking care of that patient. You didn't send them out of your practice. You know, I've heard that too. You know what? If they're not ready to proceed and they don't have a dental IQ of whatever it is, send them to somebody else. That's ridiculous. You know, that's ridiculous. So I've had those patients, and then a couple of years later, something goes wrong, and you know what they say? You know, you told me this was going to happen, and I'm ready now. You know, and now they go through the process, but they've gotten to know your office, yourself. They know that you're ethical. You know that you're there to take care of them. You're not trying to sell something. It's a totally different game. So that's what I would do with those patients that just can't afford to jump in yet. Don't send them down the road. Let's still try to do the best we can to take care of them. And that's where most dentistry kind of is today.
Right. And that's kind of a timing issue too. You think, you know, it's almost like the flywheel concept. If you're doing really high quality exams every day, making connections, some of these things just timing wise, they show up in your office 6 months later and you're like, that's so great. You know, and so you're planting all of these seeds that will grow eventually. And that's kind of how you have to think about it, right?
Yeah, absolutely. Absolutely.
Yeah.
So, and that next slide too, Kirk, is the 3D workup again. You kind of get to that because it helps idealize how you're going to optimize function and aesthetics. And really, again, you get to that to get to the treatment plan. You know, if you get to the treatment plan, they got a yes, then that stuff's what sets you up for doing the actual work, which now, if you've done that great pre-workup like that, makes the actual treatment a lot more predictable and streamlined and efficient, especially if you're doing multiple teeth. You know, because there's another thing, you know, like how many, especially if you get with young dentists, how comfortable are younger dentists working on multiple teeth? Like, you know, what's the number? You know, what's the number? Is it 2, 4, 6, a full arch? I mean, you know, you can do any of those, but you know, the other thing about sequencing treatment a little bit sometimes is for you and not necessarily the patient.
Right.
Because let's say they need a full mouth rehab. Does that mean you have to do an upper arch and a lower arch all at the same time? Well, you know what? If you're really good and you like doing that, absolutely go for it. That's, you know, that's on the practitioner's part. That's a stressful appointment.
Yeah.
I mean, that you're doing a lot to do 12, 14 teeth, you know, at a time, especially if you're taking impressions and records. That's a lot to do.
Right.
And I don't think right out of school, even if you're at the best program, that's maybe the best thing to do. So find the number you're comfortable with. Is it 4 teeth? Is it 6 teeth? Now you've got to start sequencing, maybe not based on the patient's budget, but on how comfortable you are with doing the actual treatment.
Right. And I totally agree with this because it really goes back to self-awareness. When you're a young dentist, be honest with yourself about the number. Now, the number, you still have a number when you get to your stage of your career, because the truth of a great restorative dentist is you don't have 30 full mouth cases going at a time. You have a certain number that you want to be dealing with. And it's usually a small number, maybe 6 or 5 or 8 at the most, because it's just too much to think about, right?
Right. It's a lot. Well, you know, and if you go back to the model I heard Pete Dawson first talked about, which is interesting. It's like, so to drive this kind of practice, you know, and success breeds success. So when you first start out, you know, you're not going to all of a sudden change overnight and your practice is all about what we'll refer to as these specialty patients that need this kind of care. You're not going to go all in and 100% of your patients are that. What's going to happen, though, is as you get better, you're going to get more patients to say yes. That's when that number picks up. But Pete talks about, you know, to do this kind of dentistry, and it's been true for me for the last 25 years, 12 to 15 new patients a month. Right. It's not 30 new patients. It's not fit because you couldn't, Now you got a problem. I couldn't do 30 new patient exams on patients the way that we're talking about. Right. So 12 or 15, even that doesn't mean 100% of them are going to right to treatment, but you're going to have more dentistry than you can take care of. Right. The second part that Pete said, which was absolutely true for me, is that when you're maybe going through this transition, you had what, for lack of a better term, I'll say this general practice, and we're trying to add this specialty for this kind of patients. When you go through that, you already have more patients in your practice to keep you busy for the next 5 or 10 years. Mm-hmm. And those are actually, Kirk, patients that know you and love you. So when you sit down and kind of what I will say, convert them to a specialty patient, you're going to have more patients already in your practice to keep you busy. You don't need that many outside patients. So this is not a 30 new patient a month thing. This is doing more with less. But the more isn't selling you more dentistry. The more is what's the ideal dentistry for these patients that have more advanced problems.
Right. Now, I want to pause on that note because it's a brilliant note, is that there's no one practice style that's the perfect style. If you're listening to this, you get a sense of the way Drew practices. Yeah. But basically, you're talking about those exams, that's probably about the number of days you work. Well, you're an outlier. So, but a typical dentist in this type of practice, you're seeing about one comprehensive exam per day. And this isn't 5,000 patients. Right. You probably need 1,200 to 1,100, maybe even less, depending on what you're doing, right?
Absolutely. Absolutely. And, the other point that I think you're going towards with this, Kirk, is that everybody has a blend of practice. Like, I'm not 100% specialty patient. Right. I don't have a concierge practice. I still have general patients in my practice. So at the end of the exam, if they're a general patient, that's fine. They go to hygiene. They come in every 6 months. They need a little dentistry here or there, a filling or something. I'll do that. That's fine. I mean, I don't need everybody to have to go through this whole process. But what you will find, though, as you get, what are you known for in your community? Mm-hmm. How do new patients get you? Your reputation will probably start to drive more and more specialty patients to you with time. Again, success breeds success. And for me, that's the best way to get new patients. We all need an internet presence now, and, all social media and stuff I know is very, very important. But my best patients come from my patients who are the specialists that I work with. And I know if they come through that, they're already going to go to treatment. Right. The ones I find that, one of the first things I ask is, well, it's so nice, glad that you're here. How did you hear about us? Mm-hmm. And it was through the internet. It's always a little more dicey.
Yeah. Yeah.
So, but
that's interesting. It's always interesting. Yeah. So really good things to think about, and again, when you do this, you learn more about yourself. And the key question is, how do you want to experience yourself in dentistry, and how do you best have the success during the day? Any other thoughts that you have on time? Because you can use time as your ally. Can you just add some perspective to that? Because I love how you phrase that.
Well, again, I think it works a couple ways. Is, time can be, everybody's busy now. So, right. Some patients, they can come in every week for whatever you think your care is going to be doing. But once you develop kind of your ideal treatment plan and you go to the treatment, you want to get in and get out. Like, you want to do it efficiently. You want to do it like you've done this before. So we want to work as efficiently as possible. And the only way you're going to get this is if you've done this pre-work to set things up ahead of time. If you haven't done that, I think then treatment's going to take longer. You're going to have extra steps. You're maybe going to have remakes. And, we all know remakes is an exponential cost to our offices. And the second thing is, by using time, and by time I'm going to say maybe months or years to sequence in the treatment, then you're using time as a advantage for the patients to string things out.
Right. Right. And the thing to remember is, you're putting these together. There's no less expensive way to do anything than to do it the right way the first time. So it's okay to slow down. Absolutely. We see it often too. Young dentists go through the Dawson Academy and they've got patients in holding patterns just for a little bit, not, just say, hey, look, I'm going to do the right thing. Let's get her stable, and then cross that bridge when we get there.
Absolutely. Absolutely. Yeah. And the next slide, the 6th slide there, this was always the killer one for me when when I thought I was developing the most ideal treatment plan, and I sit down and, of course you're going to have this treatment. I just spent all this time, and I just did the greatest presentation in the history of mankind, and you're saying no? Mm-hmm. So, you got to get by that. But I think the key to that is you got to start this earlier on. Treatment planning starts at the examination, not at a treatment plan appointment.
Yeah, I agree. I would say whenever things go bad or if you lose, don't lose the lesson, because there's something to be learned in each one of these. And you mentioned it before, you present this beautiful treatment plan, the patient falls on the floor and you go, is that a yes or is that a no? Let's just go right to the heart of it. We don't want to be rejected. It's not really about the money. It's about the rejection, right?
Yeah, absolutely. Well, and then the other thing for the doctor, and I get it, and I felt this way, is so you've invested time and money to go to a post-grad academy like the Dawson Academy. You've traveled, you've spent the money, you've done it, you've learned it, you've implemented it in your office, and then patients start saying no to you. Well, now you question, why did I do it? This isn't this isn't helping anything. But that part, that getting the patient to say yes is so critical. But again, it's not about smoke and mirrors at a treatment planning appointment. I mean, I read this in journals all the time, how to do your treatment planning appointment. I'll be honest, I normally don't go to treatment planning with a patient unless they want me to do it. Mm-hmm. So I have a very high case acceptance, but it's also, in some regards, it's a fake number, because at the end of the exam, if they don't want me to go forward, I don't go forward. Yeah. I'll do my best to take care of the bacterial stuff and park them there. I'm only going to go through all these records and this treatment plan and anything else if you've already told me that you want a yes. Right. And we've had some kind of conversation. So otherwise, why do it? Because I know early on, I did it for everybody. I had models and I had rejections, and it was a tough way to go. So
right. So what you're saying is you only take shots that are right in front of the goal, right? Yeah. So your percentage is higher. But, take us in, again, people love the mechanics of this. So typically at an exam, you're looking for indicators in which patients truly want to do this. And then you're having this conversation when they come back for consult. Can you tell us just a little bit about the mechanics when you think about that? Yeah, and I don't mean to confuse that issue too much, because I'll be honest, I kind of do it a couple different ways based on the patient. And here's what I mean by that. And it depends on how your reputation grows and everything else. But let's just say you're starting this for the first time. Right. You do the examination, you do the co-diagnostic process, and if I don't see too much right then, and I think they're kind of the general patient, I'll just have a review of what we saw. Everything's great. The next time they come in, they go to hygiene. Okay. But generally for our patients when they call, and again, you got to realize that patients don't know how to call your office and say, I want a really thorough exam. They just know to call your office and say what they've always said when they've made an appointment at a dental office is like, I need a cleaning. Yeah. So we have, and again, this talks to the integration when you have to do this stuff through your whole office, your whole team. Your team is so important to this. So we have a patient call. My receptionist, one of the conversations that she has is Dr. Cobb likes to sit down, do a thorough exam with you. We'll get you into hygiene. We're going to give you 2 appointments. They're a week apart. Mm-hmm. I don't do hygiene at my first exam. Okay, tell us why.
That's a paradigm shift, because, a couple reasons. One is I don't know what we're supposed to be doing at the hygiene appointment because I haven't typed the perio yet. I don't know their needs. So I don't know what that first appointment would be anyway. Right. So I want to do an examination just like we talked about. And part of the conversation is, the perio and the functional stuff and the bacteria and the aesthetics and everything else. So I need that information to figure out then what is my perio treatment plan? Do they need initial prep? Do they need root planing? Are they a type 2 patient? Are they, you need to have all that info. So the first appointment is just the examination. They know the second appointment is with hygiene, but in front of the hygiene, they have a half-hour appointment with me, where I just go over in more detail, if they're that specialty patient, what I saw, and we can have a better conversation, and I'm not rushed at the end of the examination. They'll go into hygiene, but at the end of my half hour, I get whether they want me to continue and get records and everything else or not. Mm-hmm. And if they want the records, we get them right away. They say, yes, we've got it. We'll get the photos, the CR record, models, everything else. We're good to go.
Awesome. Now, let me go back to this, what you said earlier, the treatment option review. Can you just give us a little perspective on how you start that conversation with the patient? Is that where you're doing this at the beginning of hygiene? Okay.
Yeah, and then I'll also do the treatment option review after I've gotten the records and they come back, where I have more detail. Mm-hmm. So in the treatment option review, the first thing I do is our first step in the examination process, what we call the preclinical exam. And you go back to what you and I talked about a couple of months ago, Kirk, when we talked about this whole exam process. Mm-hmm. But the first thing of the preclinical exam is basically get out of the operatory. I like to do it in my own private office, and it's just a conversation, and the patient's not in the operatory, so they don't have that stress going on. And it's basically what brought you here and why. Right. And then you just listen. Mm-hmm. So the first thing I do in my treatment option review is I restate why they originally came. So that's number one. That's the first thing I say. And it could be, you told me you didn't have any problems. You just needed to come in for a cleaning. Right. So we're maybe having that conversation there. Or you said you didn't like your front teeth, or you just, broke a tooth or whatever it was. And say, so I want to restate that so they know I listened to them. Now, I also get a chance to talk about everything else that we had talked about previously, but now we've got it in more detail.
Right.
And I've got models at that point. I've got photos, a picture is worth 1,000 words. I have a monitor in my operating practice right over my shoulder there. The Dawson Diagnostic Wizard, you have all the photos in there, and it is so easy to roll through the photos and show somebody, and they see it. Mm-hmm. And so again, they're normally asking how I can fix that. Right. So it's a process of going from there.
Right. I want to ask one more question on that, because I love this and I know how you think, but how much should the dentist be talking and how much should the patient be talking? Give us a distribution on that.
That's good. And I think our preset is to say too much and to prove how smart we are. And one of the things I got from Pete is really to talk simply and honestly and openly with your patient, but then you've got to listen to what they say. And then maybe based on what they say, you're going to start to ask questions. So I think we have to probably talk less and listen more. That would be my general summation. I know it was true for me.
Mm-hmm. That was a leading question, because you know how this works. Some dentists, in all fairness, let's be honest, some dentists are so excited about this that they can't resist the fact of telling the patients everything they see and what they can do for them. But a subtle reminder, especially if you're watching a show like this, is just slow down. Yeah. And because the patient, when we talked about this, while you're putting the puzzle together, never forget it's the patient's puzzle. You know what I mean? It's not really yours.
Right.
So.
Right. And it's their problems, and we got to realize that it's their problems and we're here to help if they want us to help.
Absolutely. Other things, what are some big mistakes? I'm sure, is there any mistake that comes to mind that you're like, don't do this? This was a disaster. Now, you don't have to use the patient's name, but is there anything comes to mind that you're like, oh, that was a big turning point for me? I said to myself, I'm never going to do that again.
Well, the biggest one, and unfortunately I've done it more than once, is to drop the world's best treatment planning that is tens of thousands of dollars on somebody that really wasn't expecting it. Right. It's a bad day. It's just a bad day, because now they think you're trying to sell them something or take advantage of them, and it's the last thing that we want. And you don't go through this kind of dentistry to do it that way. Those are the worst days I've had when I've done that. And that, I think that kind of led to, there's just got to be a different way of doing it. And I think when I did that and I listened more to what Pete really said. And the other thing, I had to realize too, is that I'm not Pete Dawson, and none of us are. You got to realize that as I was learning through Pete, literally, he did have that 100% specialty practice. Mm-hmm. I mean, everybody that was seeing Pete at the time was coming from around the country to have him redo their mouth. So he put a lot of this together a lot faster because that's what his patients' needs were. Mm-hmm. But that's not most of us, So I think backing up a little bit, slowing down some, and having those conversations with patients is definitely creates a better end result.
Yeah.
More success.
More success. Well, the success too also comes the fact of repetition. You build more confidence. You can anticipate patients what they might say. But it's important to embrace the journey of learning in front of you.
Well, and Kirk too, the success is two things. The success is partly the patient saying yes. I mean, we go through this process to get yes, right? I mean, we go through all this so we can get success there. But the second success, though, is that we actually do the dentistry successful. I mean, it takes both. And you kind of said this earlier, and it kind of reminds me of something that my dad was, you've heard this, my dad was a dentist, and he taught at Georgetown. He was a fantastic dentist. But one of the things he always said to me in dentistry and, through my life growing up is, if you say you're going to do something, you better do it. And so if you're going to go through this treatment planning process and tell somebody that they need X, Y, and Z, and it's implants and it's aesthetic restorations, whatever it is, you better be able to do it. And you better be able to do it successfully, in a timely fashion, on the budget that you told the patient you're going to do it on, with no surprises. Now, I know we can always have surprises in dentistry, but if you follow these protocols, you're going to have successes with your patients saying yes, and your successes with your outcomes in an efficient, timely manner. And there's nothing better than that.
Yeah, and I'll add predictable.
Predictable, absolutely. Thank you. Yeah.
So any other last thoughts you have on because this is such an important topic. I think the big thing, if you watch this, you can understand that when it gets to discussing the fee, it's not a barrier, it's part of the puzzle. And this is where you talk about why we should sequence or possibly put it on the table and make it part of the conversation.
The next thing you got to get into at some point would be, I'll say the 9th slide, is that, one of the keys to this whole thing is, if we do need to sequence things, is how are we going to sequence it? And what materials are going to, this is one of the big things in dentistry. We have so many material options we didn't have before. But if you're going to sequence things, how are you going to do it? It's easy to say that, we can only do the upper 6 and then we'll do interim restorations on the others. But what are they? Yeah. How are you going to do it? How are you going to design what they should be? You still got to go through these same protocols and figure out in space where the teeth need to be in space to solve the problems. You still need to get there. And then the next slide too, I think, the thing too with sequence care is it can't be expensive. Remember, that's what we're trying to get away from.
Right.
So you got to have a way that if there are teeth that we're not going to treat now, but we got to do something to them. We got to put the anatomy back on. We got to put them in space where they should be. We got some aesthetic things we got to control. You got to do it in a way that's not super expensive. You can maybe do multiple teeth at a time. It's got to be time efficient. You got to have techniques that are out there already, and they got to be able to last a certain amount of time. We've talked loosely about maybe some of this taking 2 or 3 years. So how are you going to get there?
Right.
And I remember, years ago, you'd maybe do provisional crowns or restorations on some teeth and cement them in. Bells go off when I hear that now, warning, because if those things start to leak and you don't get to them a couple of years later, it's a nightmare. So we love bonded restorations because we know that those can be stable and last for a long time. So you got to kind of figure out what interim restorations that you're going to use. And the next slide, Kirk, 11, and these are just some of the options. And again, we have so many options as dentists nowadays. Composite, whether you do it directly, you can have your lab do some indirect composite tops that we do. You can start milling if you got scanners, or the lab can mill them and send them to you. And, we're all heading towards virtual, where we're not going to be doing the wax ups and the records in the traditional analog way, but it'll all be done virtually. But those are kind of the options. And you then, as the doctor, have to figure out, this is what I'm comfortable with, and this is what I can do in kind of a timely, efficient manner. Because you might have quadrants that you've got to place interim restorations in as part of your treatment.
Yeah. Now I want to go back to sequence care because if you're if you're early in your journey in dentistry, some of this seems overwhelming. You're like, Dr. Cobb, but you can go in a lot of different directions. The bottom line is you have to develop a system for how you look at cases that are in the specialty. Now, you were an integral part in designing the diagnostic wizard. Can you just talk about how you use that? Because you're not making this up on the fly. You're using a very pre-formatted thing that fits your vision for patients, correct?
Now, that's a great question. It's the key to this whole thing. And again, in journals and continuing ed things, you hear treatment planning all the time because I think so many people struggle with it. So number one, I'll say is you got to have some kind of protocol that you go through your process in, and it can't be different every time. Right. You've got to have something, that you almost like the exam. We talk about we have the exam laid out that you look at everything. You got to have a way that you're going to go through the information to figure out the solutions. So years ago, we had years ago when I first started, Pete told you how to go through things.
Yeah.
And we didn't necessarily have checklists or anything else. You'd learned it and you did it. I'll be honest, I struggled. Mm-hmm. And as dentistry changed, and remember, when I first started, I was all functional. I hate to think how old I was, or how old I am now as I'm doing this, but I still love dentistry. Mm-hmm. But then the age of aesthetics came in. Well, now how did you treatment plan for function and aesthetics? And how did those two, go together? There was a time period where they didn't go together. And then that was the age of failure of a lot of aesthetic restorations. You're putting them back in space where they were that had gotten torn up. And now you're using ceramics and your ceramics start to fail. Right. So those two have to go together. So we kind of created what I'll say is an analog or a paper checklist. And that was great, but it could be time consuming to put a case together. A complex case that needs multiple restorations, etc., would probably take me at least an hour to work up. Now, I loved what I was doing, so I would do it. But when you start throwing in timelines like that, it's harder, and you get a lot more dentists that, although they knew the right thing to do, they wouldn't do it. So then John and I kind of came up with what we referred to as the Dawson Diagnostic Wizard. We put everything in our curriculum in one place. It's got the examination, and I use this every day. I mean, it's on every day. I do every examination this way. My assistant has a laptop. She prods me as I go along. So she's part of the conversation that we're doing. It opens up that conversation now so I can explain to the patient what we're doing and what we're looking at and why. Right. So that whole conversation part starts. When we get to the patient that needs the records, I have a way to look at everything two-dimensionally and then three-dimensionally. And all the tools that we need to answer those questions are built into the wizard. I can do a workup now in 15 minutes.
Yeah. Now, this is second nature to you, but somebody that hasn't seen it yet, the coolest thing about the wizard, this is my favorite part, is that you know where every patient is in time, and it's built within it's not just a spreadsheet or a wizard that you put it through and it pumps out a treatment plan. You can go back and remember what comes next, where we go next, and it's right there. It's incredibly consistent.
Well, we this maybe isn't nice, but we built in when you go through the 2D, because there's an order we want you to go through. Right. And again, it's funny, when we had the paper checklist, we'd have some doctors start at the top, some at the bottom, some in the middle, and it alters the flow of you developing the ideal treatment plan. So what we did in the wizard is you got to start at step one, and until you answer that, it won't let you go forward. So we built in that you have to follow it in order.
Yeah, because everybody wants to jump ahead, right?
Absolutely. Yeah. And that whole thing kind of reminds me of something that my dad said, and I think I threw this in here. So if you go to slide, it wasn't in there. I had a slide of my dad. Another thing my dad used to say to his students at Georgetown is, what's the most important step to, any procedure? And this is what we're all about in dentistry. We have the procedures for everything. So what's the most important step for any procedure?
It's the one you're on.
The one you're on.
Yeah, we did show that. You're not able to see the screen, but we showed that a few minutes back. Yeah,
that's my pops. Yeah. So if you went to Georgetown, I was given a presentation once, a Greater New York meeting, and I normally have that slide up. It's just a way for me to honor my dad. And out of the audience, like 3 or 4 people answered it. And I knew right away they had gone to Georgetown because they heard that for 4 years while they were in school.
Isn't that cool?
Yeah.
A lot of good docs came from Georgetown. A lot of amazing docs came from Georgetown.
Yeah, it was a good place. Yeah.
Yeah. It's awesome. Awesome. Well, if I'm watching this and I've got questions, about tell us, first of all, about the Dawson Academy or the Diagnostic Wizard. Where can I find that stuff? And where do I start? Let's say I've been doing other courses. Drew, where can I go to find more information?
For anything, and listen, we get it. There's lots of great information out there that you can go, but I think sooner or later, and I did it too, I did kind of piecemeal all over the place. I think you got to commit yourself to kind of some philosophy and some protocol, and then you're going to have to implement it. I mean, you can listen to everybody in the world, but unless you actually put it into practice, you're not going to get anywhere. I mean, these are great intellectual conversations, and we can sit down and talk about X, Y, and Z. But unless you actually put it into your practice, you're not going to change. And this is all about changing your life as a dentist, but also providing better care for your patients. I mean, to me, it's as simple as that. So, I mean, I went to Pete because he wrote the book, and so I want to hear from him. But the other thing is I like the approach because, it's streamlined. The other thing, and I get it, I didn't want to have to take courses for 3 years. I mean, I had a busy practice, and listen, I had other things in my life, although I was really out of balance. I was in my office too much. I had other things in my life that I wanted to do. I didn't want to be spending all of my time at continuing ed or in my office. So what I liked at the time, the original program, and I think we've gotten even better at, is that there's a beginning and an end that's going to get you to taking care of most of the, I'm going to say 85% of the complex patients that are going to come your way. You go through the core curriculum, you're there. Now we have extra add-ons in the advanced curriculum to take care of different patient types and techniques that's going to kind of raise the bar further. But the core curriculum, I think, is incredibly efficient at getting you from that patient calling and you doing the exam to you getting definitive restorations in, because that's really what it's all about as the starting point. So the starting point, if you've never done this before, would be Seminar 1. And Seminar 1 is an overview of Pete's philosophy that he's been teaching for decades. And then from there, it's into smaller groups and the hands-on. And the hands-on is, I mean, you're really not going to learn it until you actually start to do it. So we have smaller groups. We do it in the hands-on. You're going to learn to be able to get these records, interpret the records, use the wizard. And if you want to find out more about the wizard, go on the Dawson website, and they have a link to the wizard. There's demos and everything else. But for me, I couldn't do this kind of dentistry without it.
Absolutely, absolutely. And if you want to say a great representation of how Drew thinks in the treatment planning process, we actually posted a link where you can watch a recent webinar on how he creates a patient-centered treatment planning process. So you can just click on the link, and then also the link to the course that Drew just mentioned. It is in the body of the post here. So click it and check it out. I'm just so grateful, buddy. Thank you for joining us today.
It's always great spending time with you. I enjoy it. Your energy is effective here. So, you've changed the lives of lots of dentists. So
I appreciate it. Well, I appreciate you, and we love this profession, and we're going to fight hard to preserve it. And on top of it, I get to have fun, and I learn stuff from you all the time. I mean, look at all these. I get good notes. I'm trying to be a good student when I listen to you. I've got some good stuff here.
So that's what my paper looks like when I listen to you.
Now I got to go back and try to make sense of it all and put it in play. So, hey, buddies, stick around for just a second while we say goodbye to everybody else. But hey, guys, thank you so much for watching. And if you enjoyed today, do me a huge favor, hit the share button, share with your friends, because obviously we'd love great information to get out there and protect this great profession that we love in dentistry. So until we see you next time, keep watching the Best Practice Show, and then also keep sending us things that you want to see. And we'll see you next time on the Best Practice Show. Have a great evening, everybody.